we're the neonatal team. We've been crash called to theatres. We've got a mum with a full-term baby. She's come in with abdominal pain and she's been rushed to theatre because the baby's heart rate has dropped. So there's a fetal bradycardia of about 8 minutes. We are called to attend the delivery. The baby's got no signs of life at birth and we do a full resuscitation from that point. Let's prep. So main things to think about, the baby's probably going to be born in very poor condition. So David, are you happy to get ready with monitoring? And if you've got ECG leads, should we get those ready as well? Chi, are you happy to organise for emergency UVC in case we need one? And if you've got a second, just jot down a few emergency drugs because we might be getting to that point with this baby. Should we estimate 3 kilos just to round it off? And Simone, are you happy to do the initial assessment and then take airway? How do you feel about intubating if we need to?
Yeah, I'm not that comfortable with term intubation.
Okay,
so I think I would prefer if you would then take over.
Should we just swap if we need to intubate then, but you start at the airway? Okay, great. And what else do we need to think about? So if you set up the intubation equipment, do you want me to quickly set up the resuscitator and then we'll hopefully have enough time to get some hats and gloves on. I'll set up the resuscitator. So I'll just set up my PIP at 30 and we'll start it in air. But we might need to, we've got a hat,
and we've got the SudsPro just underneath the first towel.
We'll remember to put our timer on and we've got a couple of towels. And Chi, are you happy to assist in the initial assessment just of heart rate and whatnot? Is that all right?
Yes. I'm happy.
Great, and we've got suction and everything.
The head's delivered.
Okay.
And the
We've got our tubes, okay.
Okay, let's try this baby.
Okay.
Stimulate the baby. Perfect. Looking at this baby, what's the colour of the baby?
Very pale.
Let's pop our hat on. Okay, so do you want me to take that towel? Yeah, if you lift the baby. I've got the towel.
I'm putting the SudsPro on.
Great.
What's the tone of the baby?
They're very floppy.
Okay, so Chi, if you listen for the heart rate.
Spontaneous respiration?
No spontaneous respirations, no spontaneous movement.
SudsPro is on.
Great.
What's the heart rate?
The heart rate's absent.
No heart rate, okay.
No heart rate.
Do you want to start with some inflation breaths then and see if we get any response? And Chi, if you sort of listen for the heart rate, see if we get any response.
1, 2, 3, 2, 3, 3, 2.
Seem to be getting pressures.
4, 2, 3.
There's no sat yet, no heart rate.
Nothing.
Three.
Okay.
Can I see any chest rise?
There's no chest rise.
Shall we do a 2-person
Yeah,
technique?
I'll, do you want me to bag? Okay, so second lot, 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. Are we getting any chest movement with those?
There's no chest movement.
Okay, any heart rate, Chi?
Heart rate remains absent.
Absent, okay. I think we should go and get a definitive airway, yeah? Are you happy just to keep bagging and I'll grab my tube?
I'm getting ready.
So I think we should do a 3.5 for this baby and let's just have a look. Let's go for 8.5 at the lips. Okay.
Got the 3.5 ready.
Sure.
PD cup and suction ready.
Okay, shall I swap with you then?
Yes.
Great, thank you. Okay, we ready? You've got suction. Okay, just going to have a look. Okay, and suction. Am I seeing anything at intubation?
There's a lot of blood in the airway.
Okay.
And the cords.
Right, okay, so lots of suctioning happening. See if I can have a go with the tube.
Get your team ready.
We get a view. So, try that. Okay, PD cap. And,
PD cup.
okay, and let's, if you give some breaths, David. I can take over if you've got some.
I can do this.
Okay. Right, so are we getting any chest movement at all with the intubation?
No chest movement.
Okay. I'm not really expecting a colour change, but are we getting one on the pedicap? Just
No colour change
okay.
on the pedicap.
Nothing
Air
came up
entry.
on the monitor yet in terms of SATs or heart rates.
Any air entry when we're auscultating?
Can't
Nothing.
hear any air entry.
No. Okay. And any heart rate? She's just listening.
Heart rate remains absent.
Okay. I'm not convinced that this tube is in. I think we should have another go because we're not getting any signs of
Shall we go back again?
successful intubation. So let's pull out. If we could just prep another tube, please, in our bag. Okay, let's just keep an eye on the monitor. So exactly the same size tube. Okay,
Okay, ready?
get that in.
Do we have SATs yet?
No, it doesn't look like we're getting any SATs ready there.
No SATs yet?
Shall we just go up with the oxygen?
The obstetrician calls over and says mum has had some acute hemorrhage
Okay.
with placental abruption.
Oh, right, okay. That might explain the pallor and the condition of the baby. So let's just get this airway and then we need to think about, hopefully we've got a cord gas coming shortly as well. Okay, ready for me to
Tube ready?
reattempt
SATs
to this?
30%, heart rate of 34.
Are we getting a heart? Yeah, I don't think we've got a tube in there. Okay. Can someone give me some cricoid, please? Yeah. It's a bit stiff, okay.
2%. Pedicap.
Okay,
Do you want to take a look at it?
yeah, I'll give that. So if you auscultate,
SATs of 30, heart rate of 30.
Any air entry?
You can hear air entry bilaterally.
okay, that's good. Are we getting any heart rate at the moment picking up?
Heart rate remains absent.
Absent, okay. So we're now happy we've got a definitive airway. I'm going to give 30 seconds
Shall I
of
fix the tube?
breaths while you're fixing the tube, and then I think we need to consider CPR. So let me give that, and if we fix the tube. Have we got cord gas yet?
Cord gas has just come, the midwife has just brought it.
Okay,
This is the initial gas. There's
Okay.
a pH of 6.8,
Great.
very acidotic,
Yeah.
with a base excess of -19 and a lactate of 12.
oh, look at the HB,
The
70,
HB is only
okay.
70,
Right.
keeping with the story.
Yeah,
And
okay.
have we asked for some blood? yet?
No, so let's get some emergency ONEG blood, and should we just recap where we are? We've got definitive airway now, we've got no cardiac output, we've done 30 seconds of ventilation breaths, we're in 100% oxygen, and still no cardiac output. We're getting any heart rate on the monitor.
No cardiac output.
Okay.
No heart rate audible.
Chi, if you go and just quickly ask the midwife for ONEG blood, and let's start CPR if you're
Yes,
happy.
I would get ready the lines and
Yeah.
I will
I'll ask for
get
them.
David to go and
Can I have some O negative blood emergency, please?
So Chi, you're going to get the emergency UVC. We've asked for
Shall
blood.
we put the ECG leads on as well?
Oh, yes, sorry, I thought we had them on. Yeah, great, thanks, David. Okay, so we're ventilating in 100% oxygen. We're doing good CPR now. We've got a very acidotic gas and hopefully going to get UVC access. And then I think, guys, our next step will be cardiac drugs. So, David, just while Chi is preparing the UVC, do you want to get some adrenaline
I need
ready?
someone to check emergency touch with me, adrenaline, please.
I've come from the neonatal unit. Neonatal drug. Which baby?
3 kilos.
Okay. Adrenaline 0.3.
Yes.
First dose.
Should we just stop and reassess while they're preparing? So if you stop the CPR for a second. So our SATs are still 30 and it looks like you were probably causing that heart rate. So let's just double check and listen, and if not, we'll keep going with the CPR. Can we hear any heartbeat at the moment?
No heartbeat
Nothing.
audible.
Okay, let's keep going with CPR. Hopefully Chi will get access.
Second dose of adrenaline. David is behind you.
Okay, we're just hopefully we'll get access in a minute.
UVC is in.
Great, so if you, Chi, wouldn't mind just taking blood for a gas. And
I'll give you
then,
this for blood gas and a group and DHT.
You may run in the gas
Perfect.
place and group contact.
thank you so much.
First adrenaline is ready. It's 0.3 mils adrenaline, and this is sodium chloride 0.9%.
Thank you.
So 0.3 mils, let's just check we're all happy. That's our first dose of adrenaline. Okay, great. Just let us know when that's in.
So 0.3 mils of adrenaline going in,
Okay,
gone in.
let's just do another 30 seconds.
Thank you.
Flush
I got it.
going through now,
Brilliant.
gone in.
Heart rate is 49, starts off 30.
Okay. I would just prepare for a second dose of adrenaline, but we'll just reassess in another
Yeah.
minute or so.
I'll let the unit.
I assume we're still just waiting on the blood. Yeah, still, someone's still getting into the fridge. Okay. All right,
Sodium
so
chloride,
should we just quickly
adrenaline.
We put a
reassess?
double two call out.
Oh, for the consultant, that's a really, is that who you meant for the consultant? It's a good
yeah,
idea.
could we
I'll
put
put that
a
call
double
out.
two
I'll
call out
put
for the
that.
neonatal consultant?
Yeah, thank you very much.
Negative blood has arrived.
Oh, brilliant.
Blood is here,
Okay.
guys.
Okay, I think we should give the second dose of adrenaline. Let's just double check our heart rate. So we're 45. Yeah.
Neonatal resuscitation team, room 6, labour ward, EGA wing, second floor.
Okay, second dose of adrenaline. Are we giving
So
0.9 mils?
mils of adrenaline.
Can't hear
not
any heart
audible.
rate at the moment.
No heart rate. Okay, let's keep
Second
doing
adrenaline
CPR.
going in, 8
Second
minutes
dose
and
of
35
adrenaline.
seconds.
Gone in,
Okay, so that's 8.5, almost 9 minutes.
flush going through. Gone
Great. Okay, let's keep going with CPR and see if that has any effect. And shall we prepare to give some blood in a moment? Let's just see where we're at. Oh, do we have that? Oh, hang on. We've got a heart rate. Do you want to just auscultate?
Yeah.
And let's see if that sounds like we're over 60. How does that
Can
sound?
hear heart rate. It's slow, but in keeping with the.
Okay, so let's stop CPR and let's prepare for blood. Have we got that other gas? I thought we had a
Oh,
gas.
yeah, I got it here,
Ah,
sorry.
Great,
So
thank
blood
you.
gas is pH of 6.87, PCO2 of 10.2,
Yeah,
base excess minus 22, Baker
Okay.
of 11, the HB is 70,
okay,
sodium 133, glucose 2.6, and
Okay.
lactate 14.
fine. So let's get that blood in, Chi, if that's okay. So that's 10 mils per kilo, we 30
So
mils.
this is emergency blood, O negative for neonatal use.
Perfect. With that gas, should we turn off the heater as well,
yeah,
actually?
it's
Good idea, yeah.
While she's putting in the blood, should we just reassess then where we are, just to summarise? So we've got a baby, mum's likely had a placental abruption. The baby's born with no signs of life. We've got a secure airway now, but there was no cardiac output. So we've given 2 lots of adrenaline, which looks like that's brought our heartbeat back. But we're still bradycardic, so we're hoping that some volume will help. So let's give that and then reassess where we are.
Blood going through 30 mils.
I think there's a very good chance this baby's going to fulfill criteria for cooling. We're still quite encephalopathic. The gas certainly fulfills that. So when we do move to the unit, which I think we're probably close to if we get a response from the volume, we'll just need to think about cooling and CFM. Yeah?
Blood
Okay,
gone through.
hopefully our
flush
consultant will
going
come
through
soon.
now.
Okay, so
Blood's
blood's
gone
gone through. Let's give it another sort of minute or so to see if we get a... Okay, heart rate seems to be coming up.
Sats off
Sats
40.
still low. We're in 100%.
Sats are coming
They're
up now.
coming up. Okay.
Heart rate is 110.
We're going to need to speak to parents as well before I can hang back and do that before we transfer the baby. Hopefully we'll be able to stabilise soon. Anyone think of anything else we've forgotten just while we're continuing our breaths? So we've given 2 lots of adrenaline and blood, okay? Other things, I guess if we don't improve, we can think about some bicarb or some saline.
Sats are much better now.
Okay.
On the 80s. Heart rate
Still in
140.
100%.
Yeah, still in 100% oxygen. Things might improve. So yeah, high risk for PPHN. So we'll need to just assess that when we get around to the unit.
Hi, Kelly.
Okay. Hi, Callie.
doing?
Hi,
How can I
good.
help?
Thank you for coming. So, do you want to just bag while I hand over to Callie? So we've had a sort of unexpected delivery. Basically, this is a term baby. The situation is mum's had a significant placental abruption. The baby was born in very poor condition after a prolonged fetal bradycardia. So the background is she'd come in with abdominal pain, and then due to the fetal brady, there was a GA Category 1 section. Assessment at birth is that the baby had no signs of life. There was no cardiac output, was very pale. What we've done is we've given a definitive airway quite early on the second attempt due to lots of blood in the airway. That seems to have been successful on the second attempt. Due to no cardiac output, we gave CPR for a few minutes, and then we've had a response to the second lot of adrenaline. However, the gas showed a very low HB, and we were still bradycardic, so we've just given 10 mils per kilo of blood, and we seem to have now had a response with a normal heart rate, and I think our SATs are improving. So in a nutshell, we're in 100% oxygen. I think we're ready to move to the unit, and we think the baby fulfills criteria for cooling, but they're at high risk of PPHN as well, so we're just going to do a few more things on the unit first. Yeah.
Well done, team. Looks like you're ready to go. Should we move around to the neonatal unit?
Great, thank you.
Well done, team. Kelly, do you want to tell me what happened?
Okay, so that was a difficult, quite complex resus. So it was a term baby. We were crash called as a neonatal team to labour ward theatre. It was a term baby, likely placental abruption. We sort of found that out midway through the scenario, and it was a full resus, so no cardiac output of a term baby. So what we did was initial assessment. We went to airway quite early, and after some difficulties attaining airway, we were able to move on to C. From there, things went fairly smoothly, but we didn't have really stability until we'd given this baby blood. So it was a blood loss and a hypoxic ischemic event leading to a sort of poor cardiac output or no cardiac output, and that's where we ended up, and we finished the sim about to move to the unit.
What do you think the main learning points were for you?
So main learning points, I think, just again being a very busy, complex sim, communication and teamwork were really essential. I think just concentrating on role allocation at the beginning, lots of communication, closed loop communication. During the sim, there was one point at which I think David had gone out for a gas to run. He came back, we threw another job at him, which was adrenaline, and so in doing that, he was distracted in giving us the gas results. So again, just about trying to have that helicopter view, which was difficult because I was doing airway as well, but that happens, that's realistic. So just trying to get lots of feedback from the team, but yeah, other than that, I think it went pretty well.
Do you feel like you had enough people on your team?
I never feel like we have enough. Probably in that sort of situation, we did need more people on hand. Just there was a lot of running to do gases and with lines, and especially actually doing CPR, so that would have freed me up. But in the scenario that we had, being in the middle of the night, I think we did the best with what we had. So yeah, I think it went as well as we could have hoped. Yeah, but lots of things to learn as usual, yeah.
Great. Any learnings from the rest of the team?
I think it went quite well. The communication was quite good as well. It was a little bit of couple of things we would change. For example, as she mentioned before, that it was too many tasks given, especially to me because I was the only nurse at the moment, so I forgot to give, I do one and then I forgot to do the next, blah, blah. So I think I would need another hand just to give my hand on it. And then about the ECG leads, I think it's quite important. I forgot to put the ECG leads even when it was mentioned at the beginning, but then the baby was very poor from very early, and we distracted with other things. And then I forgot to put the ECG leads, and it would be very helpful in terms of getting a heart rate.
It's particularly helpful, isn't it, when you have no output?
Exactly.
Because listening can be quite limited and take quite a lot of time. Great, thank you.
Yeah.
G?
For me, I think the key thing I learned would be the moment the obstetrician informed us that there was a lot of blood. I think at that point we should have urgently requested bloods or negative bloods, and had that at the back of our mind, and if anything, one of the first things we should be getting into the baby. So that was also very a big learning point for me. And also one thing I learned, which I feel is always good in every resuscitations like this, is when you're administering the blood products or the adrenaline, recap what you're giving, how many meals you're giving. So everyone as a team, we are all aware of what is going into the baby and the timing. So that was it. Yeah.
And despite that, you got the blood in very quickly. In actual fact, in the resus, but shouting out early. It's good.
Yeah, for me it was quite a stressful situation, to be honest. As a very junior doctor, I don't see that many full resuscitation as this, and I can literally still feel my heart beating. So I think from a team point of view, we did really well, and there was quite clear communication. I think what is really important is kind of recognizing your own limitations. So I wasn't quite comfortable intubating that baby. I don't have that much experience, and especially in a situation like this. I'm happy in retrospect that I actually had the courage to say I'm not feeling up for it. And then also, when it came to the chest compressions, if you're not familiar with the algorithm or not quite sure, just to better double check and speak to the team instead of just assume something. And we were talking about the pediatric algorithm of 15-2 and the NLS algorithm of 3-1, and I thought that was really good in the way that we had some communication as well, so we were on the same page.
Overall, I felt you worked really well together as a team. It felt really calm. It felt really smooth, and you did a really great job, so well done.
Thank you.
Thank you so much.